Okay, so I think we're going to get started. This is Dr. Carolyn Foster, and I have the privilege of moderating our discussion today. First thing I'd like to do is thank all the audience members who've joined. We had over 800 people register, and already we know that we're having a variety of people interested in this topic join us, including parents, case managers, nurses, physicians, healthcare leaders, and policy people who are interested in understanding the next steps to improving home health care for children with medical complexity. We have representation for almost all 50 states, Puerto Rico, and 3 Canadian provinces. I think the breadth of interest across these geographic locations really speaks to the fact that many of our experiences, which may seem like they're in isolation, are not. And I really hope that our conversations today foster opportunities for improvement and collaboration. I want to thank the Lucille Packard Foundation for Children's Health for the organization they put into making this webinar happen, and the grant funding both through the paper, the webinar, and also the other work that we're doing associated with the grant. I'm going to go ahead and introduce myself. If we can go to the next slide. So I'm an assistant professor in the Division of Academic General Pediatrics and Primary Care at Feinberg School of Medicine at Northwestern. I'm an attending physician as well at Lurie Children's Hospital, Chicago. So I actively practice primary care for children with medical complexity in our community. And I spend the rest of my time doing health services research and policy research to try to think about strategies and evidence base needed to try to make improvement to care for this population of children. So I'm really looking forward to our conversation today. I think let's go ahead and go on to the next slide as well. So really wanted to anchor our webinar today on this paper that was funded through the foundation. It was published in Health Affairs in June, and many of you, I hope, had the opportunity to look at it prior to our conversation. I'm going to give a few talking points about it after I introduce our speakers, but really the goal of this work was to highlight where are we right now in home health care for children? What are the gaps? What are the opportunities for improvement? So I really hope for those of you who couldn't, who could read the actual article, I'll still provide an opportunity to summarize it if you didn't get a chance to. Okay, let's go ahead and introduce our speakers. So the first speaker will be Kara Coleman. She is importantly going to be providing the family perspective. She's a consultant for Family Voices and an instructor of pediatrics at Virginia Commonwealth University Medical School. She experienced in her own life home health care for her children, and is an author of I Am Justice, Hear Me Roar about her experiences with her daughter. Next, we will have Molly Hoffman, who's the Associate Director of Care Coordination at the University of Illinois at Chicago Specialized Care for Children speak. Importantly, just for context, this is the Title V program for the University of Illinois. So for children in our state who need to access home nursing and other services, they have to go through her program typically. And so she really can speak to and understand the challenges of having people accessing services. Last, we'll have Roy Maynard speak. He's a physician and medical director of Pediatric Home Service and a member of the American Academy of Pediatrics section on home health, which I will provide a link to at the end. He is going to be able, therefore, to provide literally the provider perspective, the home health sector experience of what is it like to try to provide home health care services for children. So thank you to the speakers for joining us. I look forward to your comments. Okay, let's go on to the next slide. So I wanted to take a moment just to emphasize we really do want you to ask questions. We hope to keep the last third almost of this webinar for a lively discussion. We ask you to enter in questions on the GoToWebinar question box that should be associated with the platform that you logged into. Please let us know if you have any problems with that. I'll be checking for the questions during the panel conversation. I also wanted to take this opportunity to let you know that we will be recording this and slides will be available on the website afterwards. If we aren't able to get to your question, because we obviously have limited time and there are so many participants, we will do our best efforts to actually answer your questions and post them on the website afterwards so that you can access them. So even if we can't get to your question today, we really hope to still allow this to be an opportunity for all of us to connect around these issues. Okay, let's go ahead and move on to the next slide. So before we get into our speakers, I wanted to ground us with a background by starting with a family story. So this is a picture of a patient that we take care of here at Lurie Children's in Chicago. And I really wanted to share kind of her story. It's not her exact story, but it's essentially one of patients I've cared for. So Sarah is a 15-month-old who is diagnosed with an unexpected genetic disorder. And as a result, she needs a portable breathing machine to live at home and monitoring to keep her safe. Both parents were working with employer-based insurance when she was born, but it turns out it doesn't cover home nursing. So she found out through DSCC, the organization that Molly works for, that she's eligible for the Medicaid waiver. But even when she has that waiver access, it turns out that they can't really reliably identify qualified home nurses to care for her, which has been a real strain on the family. And as a result, actually, her mother had to drop out of the workforce to try to accommodate her care so she could be cared for safely. And the family had to move their homes to accommodate. I bring up this story because I think many of us are concerned not only about our patient health outcomes, our child's health outcomes, but we also care about the context in which that health is occurring, which is within a family. Okay, let's go to the next slide. So for me, when I was faced as a physician researcher with stories like Sarah's, I really made it a mission, and with the support of the Lucille Packard Foundation for Children's Health, provided us the grant funding to really conduct research to try to understand how home health care is serving children and their families. So in this paper, we really reviewed the current evidence base for access to care. We looked at what measurements, if any, were available to measure access and quality for home health care, with the short answer being there's really none. And then to identify the key driving policy concerns related to this area. Okay, let's go on to the next slide. So this slide and the next essentially summarize what I perceived as, or what we found to be the current state, i.e. primarily the problems that are occurring in pediatric home health. And the next slide is really summarizing what are the potential areas for improvement or considerations of places to start. And I want to note that what I've asked is for the three speakers today to reflect on the paper and tell us what challenges they saw and agreed with in this paper, but what other things that they would like highlighted from their vantage point as parents, as director of a Title V program, and as provider in home health care herself or himself. So here's the summary I have for the current state. First, I think we all can acknowledge that this is a growing population of children with a diverse set of conditions. They are uniquely reliant on adult caregivers for their healthcare tasks. And I think this is really important because often some of the people at the level or who might be implementing plans don't appreciate that what might be feasible for an adult patient to do on their own is not essentially effective to be able to be done for a child. Secondly, children are uniquely legally entitled to these services through early periodic screening, diagnosis, and treatment, or the EPSDT Medicaid provision, which specifically calls out home health care services. So children who are getting Medicaid or Medicaid waiver really have a legal underpinning for why these services should be available to them. Third, we highlight in detail, I hope, that there is essentially an inadequate home health care workforce pool to care for this patient population. We believe that, and we can show evidence to suggest that one of the primary drivers is the non-competitive wage for what is essentially highly skilled work. Parents and the nurses are, and sometimes essentially running little ICUs in their home, and we should acknowledge that. There's unfortunately also few training opportunities for people who are interested in doing highly skilled home health care work, and I actually hope through this conversation we can highlight opportunities that are out there for people that do exist, but that allow nurses to be able to provide the highly skilled work needed, for example, for a child on a home breathing machine. Fourth, we highlighted in this paper the current lack of evidence and quality measures available for children's home health care. Without the evidence to say, look, really good home health care matters. It improves patient health outcomes, it keeps children in the house, it keeps them out of the ED and out of the hospital, it allows families to stay employed if they so choose, then it really incentivizes states to not invest in home health care and institute high thresholds for service eligibility. What we saw in this as our fifth point is preventable hospital spending, where children are having to languish in the hospitals because we can't access home nurses for them to be discharged home to, with a lot of hardship on families and patients themselves. Okay, let's go on to the next slide. So it's unfair to bring up challenges without thinking of solutions, and that's what we tried to do in this paper. So we made some policy recommendations to try to address the gaps and areas of needed improvement. Specifically, we started with a need for enhanced access and readjust spending via payment reform. What we mean here is that if you look at a paper by Jay Berry et al. Done in Health Affairs a couple of years ago, they essentially showed that half the money is spent in the hospital and like 2% is spent at home. And we really think there's an opportunity for readjustment here by introducing increased wages to better match the high level of skill it takes to care for children in the home, comparable to other skilled nursing. And I think that that can be justified by the offset in hospital spending. Second, it's important not just to improve access, but to improve the quality of that care itself. And there's a couple ways to do that. I'm sure people have other ideas. Two that we considered was better partnership through with child-focused healthcare systems like ours. Examples are trainings. You know, children's hospitals, we initiate a lot of the care that children are transitioned to home, like a tracheostomy and ventilator. And I think we have a certain responsibility to make sure that we are making that transition home to a nurse who knows how to provide that care and technical expertise. And we're really a source of training for that. But we need to do better partnership to make that happen. The second, I think, is to acknowledge that having a person fully trained at all times for every scenario is probably not realistic. And how can we think creatively about providing real-time extension to patients, not only to the nurses, but parents too, when issues arise? And I don't know if we'll have time to talk about it today, but we certainly are working on that here at Lurie. We have 2 telemedicine initiatives where we're trying to provide real-time support to families and home nursing staff to trouble set issues so that they don't have to go to the emergency room to deal with a problem. And then the last is the need to align with adult care to improve the evidence base and inform quality measurement. With the aging baby boomer population, there's increased focus in the adult world on changes to home health care. And this is really just a nod to say, don't make changes without us in pediatrics, because we have patients who need this care too. Please don't tie all quality measures just to adult care. So that is the policy recommendations we made. And so what I'm going to ask us to do next is have each of our speakers, our illustrious speakers, reflect on these points and the points in the paper and give their perspectives. So if we'll go on to the next slide, I'm going to ask Kara to start us off.
Well, good afternoon and good morning wherever you are in the US and Canada. Thank you for joining us today, and thank you to Carolyn and to Lucille Packard Foundation for allowing this conversation to have, and it brings me great joy to see the interest and connect up with the policy recommendations of your paper and begin to move forward some much needed change in home health care. So as Carolyn mentioned, I have some professional background that brings me to the conversation today, but most importantly, it's my background with my daughter, Justice. I apologize, I feel myself choking up a little bit, as I do often, at least for a little bit when I talk about Justice. Justice passed away 2 years ago at the age of 11, but throughout her 11 years of life, we had the full gamut of home health care experience, from attendance to very highly skilled nursing care at home and hospice care in the last few weeks of her life. Throughout the process as well, my husband and I, and even sometimes our other children, were providing all types of medical care in the home to our daughter, so that we would be home where we all wanted to be and function as a family, and make sure that Justice had a great quality of life and that we all had wonderful family well-being. So it's with that I reflect in general on Carolyn's paper. I think that the gaps that were identified in it and the policy and the future directions were really spot on for my family and for families and in the Family Voices Network. There was a lot that was pointed out that many of us discuss sort of in the shadows, but haven't really been brought to the forefront in a while. And there's a lot of, or shall I say, the policy and the future directions give a lot of hope to what families think can and should be done and have been talking about that should be done, and you know, give us a great deal of encouragement. Two of the areas within the paper that I just wanted to reflect on that spoke to me very much was the measurement topic, that as you just mentioned, Carolyn, there really aren't any quality measures for home health care for children. And so I sort of wonder and ponder, you know, can you really say there is home health care if you're not measuring it in any way? Because as we all know, and have heard many stories, as Carolyn just, you know, recounted with Sarah, and I could recount so many from my own life with Justice, that having care in the home that isn't quality really isn't home health care. And it, as the paper suggests, and many of us talk about, you know, gives rise to a lot of the readmission issues and other problems that we have, you know, with people continuing to be sick or staying in hospitals, that, you know, if we don't begin to measure what we are putting into people's homes, then perhaps we're not really putting quality care into homes. The other part I wanted to reflect on in the paper was the suggestion of integrating home health with child-focused healthcare systems, and that, you know, building on the collaboration that this requires, you know, bringing child-focused hospitals, academic institutions, home health agencies, nursing education, medical education, you know, really a community together to train nurses, train other providers, to give skills. I just wanted to encourage that families and family-led organizations have tremendous workforce experience in home health care as providers themselves, as the, you know, chief care coordinators for their kids, as chief communicators, as teachers, as quality improvement specialists, because many joke that our lives are PDSA cycles over and over again, and also as advocates, and also with whatever other professional experience we have. And so collaboration to integrating and bringing value-based purchasing to the forefront really needs to include families. And with that, my final point I just wanted to make was that one thing I wanted to change perhaps about the discussion that was brought forth in this paper was you know, just making the point that families and family-led organizations such as family-to-family health information centers must be partners in care and in systems change. I don't know if many of you saw, but I wrote a blog for Health Affairs that appeared in April. It's, I believe, linked at the end of this webinar, but, you know, in it I discussed that it's sort of the elephant in the room in a way with home health care, is that we all know that families, as Carolyn alluded to, you know, provide a lot of the care ourselves in the home because we don't have reliable home health nursing or other providers coming in the home. And despite this, we are often kind of pushed out or not invited in or forgotten in the conversation about how to lead systems change, how to be a part of it, and partnering for change. So we are the engine as families that drive home health care. So it's, I guess, a plea: don't drive forward into the future directions and policy changes without us as your equal partners in thought and in care. So thanks for the opportunity to speak, and I look forward to having a conversation.
Thank you, Kara. That was so enlightening, and I appreciate you bringing up those issues. Holly, I think it's your turn to share your thoughts.
Okay, well, thank you, everybody. Would you like to advance? Thank you. To the next slide there. My name is Molly Hoffman, and I am so honored to have been asked to participate in this webinar today. I think that Dr. Foster does an excellent job summarizing so many of the pertinent problems that are facing caregivers of medically complex children in the home setting today. I also really appreciate that the focus of Dr. Foster's work is not just on identifying the problems, but also in engaging in discussion about potential solutions. And I could go on and on about how spot on she is in many different places throughout her article about different avenues that are impacting the children that we're talking about today. But I was asked to just keep my points to 3 key areas. So that's what I'm going to do. And the first area that really stands out to me really lends well to the conversation that Kara just started in her slide a few minutes ago, and that has to do with support for the caregivers. Kara, you so nicely talked about how you were working to ensure that you had well-being of your family and providing care for your daughter, Justice. And I think that so many times we forget about the fact that the systems that are in place to support families, and we have to make sure that they're working. And when we're thinking about the systems that do exist, we have to make sure that not only are they helping to successfully keep a child with medical complexity in the home, but also how are they doing in supporting the families and the caregivers that are taking care of that child. The systematic supports need to include conversations about things such as care coordination, about respite services, day services, or other creative ways to provide assistance during times that access to nursing is not available. In Illinois and likely in other states, there's a lack of respite that's available to meet the demand that exists. We don't currently have any day services in our state that work with children with technology dependence. And so we need to continue to have discussions about what other services do we need to help put in place to support caregivers so that they can be successful. The second key point that I wanted to draw attention to today that is so nicely mentioned in the article has to do with education and training of the nurses that are providing care in the home setting. We have to recognize that the level of care that's required by many children at the home is more intense, and it requires skills that are not taught to nurses in school. We have to recognize a need for sufficient training and to ensure that there's nurse proficiency before they're allowed to provide care to a child at home, especially because nurses working in the home setting don't have nursing coworkers in the room next door to ask for help. Dr. Foster also mentioned in her article a successful training that we did in Illinois that was a partnership between Division of Specialized Care for Children, our Title V program, and Lurie Children's Hospital that was called Nitty Gritty Nursing. And this was a training that we had successfully put together for home nurses on elements of care such as ventilator management, trach care, central line care, and is something that's being shared in different parts of the state by different medical experts. And that there are a few things that really, I think, contributed to the success of this particular training, and there's a lot more related to training that we still have yet to do. But a few of those things worth noting is that, one, there has to be a mechanism for conversations at systemic levels about the gaps in care that are being identified. Two, that there needs to be funding that's set aside to help with those training costs. And that the conversations about training really, they need to continue, but they also need to include quality oversight, which is a really critical piece. And Kara, you commented about that as well. And then the last point that I wanted to draw attention to today is something that I think needs further consideration for the future, and that has to do with a single point of entry for services. So in Illinois, our program serves as the single point of entry for children, pediatric children who need shift-based nursing care in the home. And I know that how nursing care is accessed in different states looks differently. But I think it would be really great if there was continuity in the way that those services were accessed, but they also included more than just how do I get a waiver to help offset the cost of nursing. If we were looking at having home assessments that included things as somebody coming in and saying, your child's coming home, this type of equipment and this type of access in and out of the home and vehicle transportation, et cetera, could help you be most successful in taking care of your child. And why can't we find ways to simplify some of those things that can be quite complex for families? So I really look forward to being able to engage in conversation with more of you about solutions and some next steps to really trying to help families be the most successful in caring for their child with medical complexity in the home setting. Thank you.
Thanks so much, Molly. That was really great, and I'm excited to hear people's comments reflected back. Okay, Roy, let's go ahead and share your comments, and then we'll move into the panel session after that. I just want to encourage everyone to please go ahead and put questions up if you have them. I see some people are already starting to put them up, but as comments are made and you'd like more information or want me to raise the question later, please start sending them in. Go ahead, Roy.
Thank you, Dr. Foster. I will preface my discussion from the perspective of working in home health care, with the focus being in Minnesota, recognizing the fact that some regions of the United States are affected differently by these issues. And I am the medical director for a home care company in Minnesota. One factor that needs to be recognized is an expanding population needing home care. We're completing a research project in Minnesota looking at the prevalence of children with tracheostomy over the past 10 years. This population of technology-dependent children is expanding disproportionately to the population of children at large. This is probably not unique to Minnesota. Provisions need to be made to ensure home health services and other resources are commensurate with the needs of this growing population. As you mentioned in the Health Affairs article, there's a shortage of home care nurses as a major factor. We looked at home care nursing availability in Minnesota and the impact it has on delayed hospital discharge of 185 children with medical complexity over a year. The paper was published in Pediatrics in January. We found the greatest obstacle to hospital discharge was a shortage of home care nurses. This contributed to 1,454 delayed discharge days waiting for nurses. On average, pediatrics patients spent more than 50 extra days in hospital and added $171,000 to each patient's healthcare costs. Overall, the cost to the healthcare system in Minnesota was increased by $5 million, monies that could have been spent elsewhere. Regarding healthcare disparities, there are substantial variations across state lines for Medicaid-funded access to home health care. Access to care, however, can be an interstate issue. Within Minnesota, disbursement of waivers is inconsistent and varies from county to county. There is now a cottage industry connected through social media to help Minnesota families move into counties that are more generous with waivers to fund home health care services. Regarding reimbursement, payment remains an issue for home care nursing across the nation. Nursing agencies often must balance private pay versus Medicaid patients to remain profitable, and this may affect how nurses are paid. Better reimbursement from private insurers incentivizes nursing agencies to provide services to these patients in lieu of patients on public insurance. Nurses should be paid for what they do, not where they work. In Minnesota, home care nurses make $10 less per hour with less benefits than hospital nurses. In addition, if their home care patient has a prolonged hospitalization, they're not getting paid. Consequently, there's a high turnover of home care nurses as they seek other employment. Regarding recommendations, I think we need to recognize that home health care nursing is a specialty, just like an OR nurse or an ICU nurse. Improving reimbursement may ultimately help with recruitment and retention. As addressed in Dr. Foster's article, expand the option of paying parents and family members to care for their child and to help decrease financial hardships. In Minnesota, parents can use waiver funds to pay themselves as a PCA for up to 40 hours per week. For parents that are RNs, they may get paid at a higher level. Regarding allocation of nursing hours, priority for RN level skilled nursing should be for high acuity patients, not low acuity patients. Nursing agencies and medical providers need to be held accountable to properly assign home care nursing hours. There's too much variation across and within states regarding access to home care. Consider standardizing the allotment of nursing hours based on medical complexity. As already alluded to by both of the previous speakers, we need to improve the quality of care and outcomes by standardizing the training of home care nurses. Promote fair disbursement of waivers that fund home health care. The last point I'd like to make is what can be done to escalate the level of home care access when a patient's acuity increases in order to prevent hospitalizations or an emergency room visits. For example, respiratory hospitalizations for children with tracheostomy are often short, 3 or 4 days. If home care services were increased during this time, could hospitalizations be avoided? Would need flexibility in scheduling nurses and payer support. I think this is an area where we could consider child-focused healthcare systems could collaborate on this. And I think I'll stop there and turn it over to Dr. Foster.
Thank you so much, Dr. Maynard. That was wonderful. I really appreciate you bringing those other points, and it's actually been very fun to watch you raise some of the issues, and I'm seeing similar questions come up from our audience. Many topics have already been raised, and I want to start our panel discussion with highlighting the fact that all three of you, I think, elevated the concern for training and quality. We have a couple questions already of people saying, like, how can I get the training that you've spoke to, Molly? And I think we'll certainly reference that on the website afterwards. But I think if people who are aware of trainings that are happening in their state, we're happy to connect people if that's of interest. But I will say my understanding, and you can speak to this more, Molly, is really that training happened because of essentially local interest and effort. And so I think we can think strategically about making some of those things available on a national level, but it really came from local effort. And then the other two pieces that I wanted to highlight were an emphasis on family support and specifically the opportunity to provide payment directly to families, which isn't exactly what Kara was calling out, but I think connects to this need to directly support families. So just to start our conversation, I wanted to just back up 1 second because I've had a couple of people ask the question of what is a Medicaid waiver, and so I realized I maybe got a little ahead when I started giving my introduction. And Molly, I apologize for putting you on the spot, but you may be the best to summarize quickly what a waiver is for those on the line or those in the audience who are not totally versant in that. Do you mind just giving a quick summary?
Sure. So waivers are something that exists through states' Medicaid programs, and there are different waivers dependent on the state. In the state of Illinois, we have several home and community-based waivers that are available through our state's Medicaid program, and it's the medically fragile technology-dependent waiver that our Title V program has a partnership with our state's Medicaid program and working with. And when there are different eligibility criteria that exist for each of the waivers, but parental income is waived in a waiver. So all individuals are eligible for those services, assuming that they meet the other criteria for eligibility.
Great, thanks so much, Molly. I hope that helps. Since so many, I think it's important because so many of the children who do access services do so through a waiver. So it's important to have that shared common ground. So one of the topics that Roy brought up was this issue of expanding access to paid family caregiving. And I wanted to know, Molly and Kara, what your thoughts were on that, where you've seen strengths in that or challenges. Kara, do you want to start maybe?
Sure. In my own personal experience, at one point when Justice was, through her waiver, was using just attendant care, my mother, who was a former, long time ago RN, but she was paid as an attendant for her, so I could go to work, and then I would come home and do the skilled part of her enteral feeding at the time, and it worked very well for us. It was very hard for us to find an attendant that was reliable. that wasn't afraid of a child who was nonverbal and non-ambulatory and all those nons. So it provided flexibility. So at the time I was still practicing law at a nonprofit and was able to carry a caseload. And that provided flexibility for me to be able to care for my daughter and have somebody I knew I could trust in the home that was reliable. Once she moved into much more complex medical care, that was not really an option in terms of the nursing here in Virginia with waivers, but I definitely saw a need for it, in that many times the nurses that we would get in the home through whatever health agency we were using, home health agency we were using at the time, would often come into the home. For example, Justice at one point was just on 22 hours of TPN and not receiving any enteral feeds, and we were given nurses in the home who were not trained or not allowed legally to be doing anything with her central line or providing TPN. So that meant mommy RN had to step in and figure out how to do it all and provide the care. And at that time, I did have to step away from work. So it would have been very nice to have formal training myself, which I didn't get initially. And so having a nitty gritty for RNs and families would be really great, Molly, if you want to work on creating that curriculum. But I think it would open up flexibility and, more importantly, recognize that families are providing a lot of skilled nursing. Even if you have nurses who are skilled, there's a lot of lack of reliability of people coming or turnover because of poor reimbursement and so many other factors, that having flexibility to pay family members or friends or people that you can trust, you know, allies, to provide care would just improve, I think, the consistency and the quality of care for kids and families.
This is Molly. Just to add on what Kara just mentioned, I think what we have in Illinois is fairly similar to what you just referred to in Virginia, where there are avenues in which families can be paid as a caregiver, but it's usually through programs that are offering the training at the attendant or personal assistant level. But when a child has a level of need that advances to require skilled nursing care, that we don't have anything in place in our state currently that does allow the family to be a paid caregiver in those instances. And I think part of that has existed. I'm not saying that I agree with that, but I think part of it has existed because of that skilled level of care. And people saying, well, I had to go to nursing school and pass a certification exam, and that's part of what makes them qualified for additional need that you know, some of these children may have. And I think that as we're seeing an increased demand for nursing in the home setting, and just as Roy mentioned, continued growth of the population of children with special health care needs, I think we need to continue to have conversations at the systemic level about what type of support from a financial standpoint may be applicable to families who are providing care.
Thanks, Molly. I really appreciate that. And Kara, I wanted to, there was a really interesting question that was just posted about kind of flipping our conversation on its head, saying, oh, look at all the challenges with these jobs. And someone said that I think is an interesting question, is like, how do we actually flip this on its head and make the jobs, besides the pay, which I think we all agree is necessary, but how do we advertise, or maybe this is a question really for you, Dr. Maynard, is how do you advertise those jobs? How do you make it appealing so that people want to do the work? And then I want to transition to a question that's being raised about children who are not eligible specifically for nursing, but for care that would be a non-RN level care. But let's start with the question about how do you advertise, how do you sell the job?
Well, that's a great question. You know, the organization I work for is a very large organization. So we have a respiratory therapy department, we have dietitians, we have a specialty IV pharmacy infusions. It's a pretty large setup here. So we have the ability to incorporate some of the home care nurses into our organization. And that is done by holding special little dinner parties where I'll often give a lecture and they can get a CME credit, so they can come together as a group. We also have company-based meetings, and they're all invited to those things, which really helps a lot. But it's a tough place to bring in. You have to recognize that most of the people going into home care nursing are young nurses, usually right out of nursing school. They don't have a lot of experience, so they look for employment to get the experience so they can get a hospital-based job. So trying to retain them after it's a real problem. To put this in perspective, in 2014, we looked at our retainment, and if we hired 100 nurses 2 years later, 85 had left and only 15 were still in home care. So to incentivize it, we developed a you stay, you pay program where the nurses are given bonuses if they stay beyond a certain period. That's been very popular. We've increased the flexibility in their schedules, so those of them who have young families can work around that. And we have very specific and high quality training for the nurses, so they are well prepared when they go into the home. And in fact, I think both of the other speakers, Karen and Molly, discussed the point about proper training for home care nurses. And we just had a paper submitted on the home care curriculum that we use, including basic course. We have a simulation lab for training the nurses with tracheostomized patients, and then how we preceptor the nurses in the home before they're allowed to be in there independent, and then the ongoing continuing medical education and annual competencies they participate in. So, and one last point I want to make is that one of the things that many people may not realize is that the schools that are training these nurses, they get little or no introduction to home care. So it's never really brought up as a specialty for them. And one of the things that we've done is we actually bring in nursing students and we put them through our simulation lab to expose them to see what it's like to be a home care nurse. And so far, I think we've had over 300 students come through just to be exposed to home care.
Thanks. I think those are great examples. Molly, Kara, any other thoughts about, if you were to be part of the advertising of why this work is so important, why you should be working in home care, what would you add for those who have posted questions about that?
Yeah, this is Kara. If I could just share a few thoughts, that would be great. I think this is a really good place that of an example of a way we could really partner with families. As you started off this webinar, Carolyn, you grounded it in, Sarah's story, and that's what it's about. Home health nursing is a specialized type of nursing, and it's one that if you want an ICU environment, you can surely have it in the home. But you don't just get that kind of training and skill development, you also get the life, which is what it's really about, right? The quality of life, getting to know Sarah, getting to know Justice, relationship-based care and family-centered care really at its finest. There are definitely challenges of working on your own in the home, except, if we're partnering with families to really craft this message, we're teaching how family professional partnership at an individual level and at a systems level can happen. You are in a home, you're getting to know, our nurses or Justice's nurses. I often, as I just did, call them our nurses, just as I call many of Justice's, providers and physicians ours. They didn't take care of me, except those who are working in a home health field have the opportunity to have relationships with every single one of my children and all of our family and go on vacations. And it's in that making sure you're providing the clinical medical care so that your child, Justice or Sarah, get to go to school and get to do the things that really matter in life. Otherwise, what's the point of doing the clinical and medical care? So I think a home health nurse, if we can peel it, if you really want to make a child have a life and help carry it through from end to end. You get to go to school, you get to do all this stuff and see their boyfriends and help them get ready for prom and make sure the trache's in line for that and everything. But there's some really cool, creative ways we could craft that message together as partners and families, with families.
Thanks, Kara. Molly, anything else from your experience? Otherwise, I'm happy to move on to the next question.
I really would say that I agree with a lot of what Kara just said, that a lot of it needs to involve asking families about what has been successful for them in being able to retain nurses that have been working with them for some time, and finding ways to have families share those suggestions among one another.
Thank you so much. I want to just answer a quick question that we have on here. There's a question about there are adult programs such as hospital at home at Johns Hopkins that are able to provide quote unquote hospital care at home to prevent hospitalizations. Do we know of any comparable ones for children? And I do know Mount Sinai does have one. Dr. Ling Chen who I can connect you with, Dr. Bergman actually does that work. So if other people know or are interested in hearing more about what essentially is like admitting a child for more acute care at home, those programs do exist. I did want to ask this question, and I know that we've been talking about it, the speakers prior in our preparatory work, but one of the things that I'm seeing elevated here is an addition in the questions that I'm reading is a concern of not just the children who are of high enough need to require nursing care, but children who may need more help with activities, primarily help with activities of daily living, who may not be eligible, therefore, for an RN or an LPN level, but someone who, and I really am very careful here to not say non-skilled work, because I want to just be very clear. I think it's really important to acknowledge that helping someone with activities of daily living is actually extremely skilled work, especially a child in the family context. So I just want to call out, what are your thoughts on, is the conversation really any different for that group of patients and that particular provider pool, or do you see a similar themes? I mean, I personally think that the themes are very similar around making sure the eligibility criteria are consistent across states, that there's probably a dearth of providers, that the pay is really low. But for any of the speakers, would you like to comment on what is different, if at all, about providing quote unquote activities of daily living care? And I realize I didn't pose that to anyone. Yeah, go ahead. Go ahead, Roy.
Our organization, we don't have personal care attendants, but the one comment that I would like to make is that up until I retired from clinical medicine a few years ago, I absolutely saw patients that did not need a skilled level RN who would have done just great with a primary care attendant, someone to help with those types of activities of daily living. And, you know, the money was being spent to pay for an RN and somebody was signing off on it, not me, but another physician. And I think that's where we really need to make sure that we hold people like nursing agencies and medical prescribers accountable to make sure that the appropriate resources are being put in the appropriate places.
This is Molly. One thing maybe just to add to that is that in Illinois anyways, it's a little bit more decentralized as to how do you gain access to services through personal assistance. And going back to the point that I brought up earlier about those single points of entry for services, I think that there's opportunity for states to have discussion about ways to develop more centralized access to all types of services, whether it be at a personal assistance level or a skilled nursing care level, to help make sure that the child or the young adult or adult moving on gets linked with the services that are most appropriate for them and that best meet their need.
I guess I would just make a couple comments that, Carolyn, I greatly appreciate you pointing out and hesitating to call, PCA type work, those focusing on activities of daily living as unskilled work, because as you point out, it is really skilled work. It requires, just this. I often phrase it, it's one of the greatest gifts that justice ever gave me, was this ability to learn to look at life through a lens of accommodation, and what came with that was creativity. and flexibility. I often joke that I'm a reformed type A personality because of that gift from justice. And the type of work, I think that the parallels between any type of home care are very similar. I don't think they're different discussions, and particularly around the issue that we've danced around today too, of who's getting paid, scope of practice, reimbursement rates, structure, and all that. And I would just even further the parallel a little to, you know, many of our kids are going, you know, into school, and we see this sort of same turnover structure issues with workforce in special education, that there's teachers and then there's whatever they're called, instructional assistants, one-on-ones, paraprofessionals, whatever they're being called in your respective state. And it's a very similar thing, although there is often a lot of paraprofessional turnover. In schools, there's not as much, perhaps because there's a little more structure and benefits come with it and some other things that don't come. So I think that kind of leads us into the discussion. We really need to look at the reimbursement rates and how we're supporting providers in the home and the training that's provided, you know, in addition to their workday and other stuff. But I think it's all really part of the same conversation.
Thanks to each of you for your points on that. I think it leads me to a couple of items that have been raised by our audience around, okay, so we all agree that there's these issues. I think the question is, what are the strategies that we should use to take to our legislators who control the purse and the flow of dollars? I think there was also a comment about private pay. What's the role of private pay in this? And I think that would be great. But let's just start with the state legislatures. Certainly, Kara, I know you've worked extensively in advocacy, and Roy, I know a lot of the work that you're doing is in research is actually trying to provide the data, right, to show that this is kind of a fool's errand. And I think one thing I wanted to highlight from, which I actually in the health affairs paper that I wrote, I actually referenced your article about how you documented the wasted money of children staying in the hospital with delays compared to what would have paid what it would have cost to pay home health care for that equivalent time. And I really want to highlight from my perspective that, and this is my bias to be honest as a physician researcher, is that data is really important. Having partnerships in your state with people who can help look at data to make the case for why the money that is being spent by the state already is being, I would say, unideally spent in the hospital on days that they would have children otherwise would have been at home is very compelling. I think another place where data is really important, and this is what I'm trying to work on now, is making the case for the workforce implications Kara has already alluded to, that okay, if you don't pay for a person to help a child care for at home, that is a parent who's dropped out of the workforce, and that's part of the economic labor of a state. And I think those are compelling arguments made to legislators. So that's a place that I would like to start that piece of the conversation, but then would open it to Kara, Roy, Mally, whoever feels like you want to comment of like, what do we do? What are the strategies to legislatures or legislator or state reps? Yep.
I can jump in here because I do have some experience in this. 5 or 6 years ago, I went to our state capitol and discussed the project that I was starting, which you referenced. But basically, we had some rough data that confirmed what the costs were and the money that was being wasted. And our state legislators, after I testified, ultimately agreed to a pay raise for home care nurses. Now, it was very modest, but they did get a slight raise in funding for home care nurses, and it was stipulated that 85% of the monies had to go towards the nurses' salaries, only 15% to overhead costs. So when you're lobbying at the state level or the federal level, you always have to recognize the person you're talking about is the home care nurse, not the company. Money needs to go to the nurse.
Thank you. Any other comments about, yeah, go ahead, how to make a case? Yeah.
Yeah, I think what I love, you know, you're talking about data, both you and Roy, and grounding it in that, you know, sort of evidence-based medicine data. And for legislators and policy people, it's about the fiscal bottom line, right? And so I think taking that and very succinctly laying out, we are not spending our money right. Look at some other ways we can spend it. And along those lines, I guess I'll take us back in history to Julie Beckett and the efforts that she did with legislators in creating the home and community-based waivers to get her daughter out of an institution, out of the hospital, into a much more cost-effective, safe, quality of life driven, family centered, whatever you want to call it, real life, into the home to provide care. And that is why and how we are able to care for our kids at home. I think we're at another sort of turning point in which, families and professionals have to jointly go back to the legislators and say, okay, we've built this system, but it's not quite working right. Here are the ways that we, here's the evidence, here's the data, here's the money, here's how we can get it done. And do it together.
I think one of the things I want to highlight about what Kara just said is it's going to take collaboration, between a variety of entities, providers, families, to make the case jointly. I think if it's done in isolation, it's far less likely, with all the competing interests that states have, right? They're focused on education and pension systems, at least in the state of Illinois. And so it's really important to bring that forward. And I sheepishly do not want to in any way discount the powerfulness of family stories. I think that paired with data is very compelling. If nobody else has any other comments on that, I did want to call out a couple people have mentioned a question about litigation that's been ongoing. And we did mention this actually in the article. Yes, a variety of people across many states are using litigation under EPSDT Medicaid provisions as a possible solution. I know we have a decree here in Illinois to raise the wage. I know the Northwest Justice Project in Washington State was able to litigate successfully, and we referenced some other litigation in the paper itself. So if people are looking for specific resources, there are referenced in there, but feel free to follow up with us afterwards. Another interesting point that has been made is, does anybody know of best practices in different states? And personally, in my search so far, I have not found those. That was part of our interest in looking for measurement, access and quality measurement. I'm just curious for the other speakers, have you come across quote unquote best practices from your kind of vantage point?
This is Roy. I can jump in here. There's a paucity of data on this. The field of pediatric home care is uncharted territory. And I'm just in the process of finishing an article for how we allocate home care nursing hours based on the children with medical complexity. If you do a search, you're not going to find anything in a peer-reviewed journal on how to do that. Not that we're right or wrong, but at least we're putting it out there. And then we have two other articles that were just accepted for publication on best practices for pediatric home care nurses. That'll be published in March.
All right, thank you. I just realized I got so excited about our conversation that we're over time, so I apologize for that. I really want to thank the audience for all their interesting comments. Clearly didn't get through all of them, but we will be going through them and trying to address them either to the specific person who was referenced to or answering them as a group. I also wanted to call out these additional resources. So there's Kara's healthcare blog, Health Affairs blog that she wrote, which I think really underscores the family perspective. I also really would like to encourage all of you to take a look at the American Academy of Pediatrics section on home care website. We would really encourage you to join. My understanding, I'm not an expert on the rules of AAP, but you do not need to be a physician necessarily to partner. We certainly have families partner through liaison activities and nurses as well. And then please feel free to reach out to me afterwards if you have any additional questions. Thank you so much. I want to thank the speakers again for their time and their insights, and again the Lucille Packard Foundation for Children's Health for sponsoring this. I hope this is just the beginning of a fruitful conversation on this topic and future collaborations for those of you who joined. Thank you so much.
Thank you, Dr. Foster.
Thank you.